તો આ આખી પ્રોસિજર સમજાઈ ગઈ. ડોક્ટર બેંકર, જેવી રીતે તમે જેનિક્યુલર આર્ટરી એમ્બોલાઇઝેશનની વિડીયો બતાવી અમને, એવી આ હિલ પેન રિમૂવ કરવા માટેની પર પ્રોસિજર બતાવશો?
યસ, ડેફિનેટલી. આપણે સેકન્ડ જે વિડીયો છે અમારો એ હિલ પેન એમ્બોલાઇઝેશનનો, એ આપણે જોઈએ. Hello everyone, we welcome you all for our conference Magical Formula 2021, and in this conference we are going to show you the magical formula, magical treatment for the knee pain and heel pain. And today in this session we are going to discuss for the one case about the heel pain. Heel pain is very common in society, and two most common cause of heel pain is a plantar fasciitis and second one tendinoachulitis. And we have Vascular, and she is from tendinoachulitis since long time. And let me ask her a few questions about Asmitaban. What are symptoms in your leg, and when it was started?
It started off way back in 2012, but it was a little bit of pain, which I used to endure it for a long period of time. But then in 2019, something drastic happened somewhere on the airport or somewhere, and the pain aggravated to a very great extent. And then it was becoming very difficult for me to have my normal work schedules and my walking schedules and everything. And I was much worried about it, consulted many doctors, but they said that there is no surgery, like painkillers would be the only option. The surgery is very tricky and very dicey, so it's better not to go for the surgery. So anyway, I was bearing with that. That's how it is. And then I came to know about you people, and then I consulted you.
So this pain was, I think, disturbing you lots of time in your professional life also.
Oh yeah, I was a teacher, and my profession obviously is of standing and walking all the day long. So yeah, it was hindering me in my profession as well. That's true.
Okay. And whenever you are doing some exercise, some jogging, and at that time also you are feeling the pain?
Oh, I miss that. I'm an evident walker. Like, yeah, I really like walking morning walks, and I had to discontinue that after 2019. Yeah, 2019, before COVID, I had to discontinue with my regular morning walks because that was too painful for me.
Now, one more question about the Asmitaban, about the characteristic of the pain. So when you are awake in the morning and when you do the first step out of your bed, how was your pain, and that pain gradually relieved or not?
The pain when I get up in the morning is too excruciating, and it doesn't go. It goes slowly, of course, but it doesn't go by maybe 100 and 150 steps till then, and then slowly it does reduce but doesn't go away totally.
Okay.
Yeah.
So, and these everyday's affair.
That's everyday affair. Yeah. Not only just everyday affair. Like, even if I rest for few hours, 2 hours, 3 hours, and then if I get up again, the first few steps are really, really painful.
So typically there is the tendinoachulitis pain or plantar fasciitis pain. So there is a inflammatory pain, and this pain is typically very more in intensity after prolonged resting hours. So whenever we take the rest, like we are sleep in the night for 6 to 7 hours, and the first step after the bed, it is very painful, and gradually little bit of pain intensity is reduced after few 100 steps or 200 steps, and this is typical of inflammatory pain. And such kind of tendinoachulitis pain or plantar fasciitis pain, this treatment is very, very useful.
An antegrade puncture of the left femoral artery, common femoral artery, and with a 4 French sheath, and we'll be going super selective into the vessels supplying the plantar fascia or the tendo Achilles, and we'll go with the help of diagnostic catheters and our special wires. We'll go from the superficial femoral into the popliteal, and from popliteal into the posterior tibial artery. This is done under continuous fluoroscopic guidance in the, as you see in the cath lab machine, angiography machine. We take DSA, digital subtraction angiography, from the distal popliteal artery to map the calf vessels. There are 3 calf vessels, anterior, posterior tibial and the peroneal. So we'll be going in the posterior tibial artery. We use microcatheters for superselective cannulation. They're very thin catheters and they don't damage the vessel, so we can go super selectively in this. So we are inside the tibioperoneal trunk. Wire apo. This is the super selective diagram of the tibioperoneal trunk, and from here we'll go into the posterior tibial artery. Roadmap apo. So what we do is we take a roadmap, so we know exactly where we are going in real time.
So there is a case for heel pain, and when we are talking about the heel pain, there are lots of causes for the heel pain, and there are a few common causes as plantar fasciitis and tendinoachilitis, and there is at least 20% of the patients from the heel pain, they are suffering from a neurological pain. So there is one nerve which is passing through the calcaneum, and if these nerves got compressed, then patients have continuous neurological pain. So these all things should be differentiated. The source of pain, what we are targeting, it should be the inflammatory origin.
Remove roadmap.
So this is very good for tendinoachilitis, with plantar fasciitis. This treatment works wonderfully in such case. Now another things it should be noticed for this heel pain, particularly for the plantar fasciitis. Many times cortisone injections is given. So these are steroid injections given for the treatment of plantar fasciitis pain, that is heel pain. And what happened that this steroid injection actually giving more fibrosis into this tendon, and actually it damages more rather than helping. So now let's look on the angiography.
We have gone very super selectively in the posterior tibial, very distally up to the ankle joint. Let's see what the angiography says. NTG Abjo. So there is hypervascular blush at the site of Achilles tendon insertion at the calcaneum. You can see rest of the vessels and rest of the plantar arch. They are not showing any blush. They are just branches are seen, but not the blush is seen. Here we are seeing the blush of the inflammation, the inflammatory blush at the site of insertion, and that is the site of the pain clinically also. So everything matches with the inflammatory pain here. And what we'll do is we'll go super selectively in that branch supplying the blush, and we'll embolize it.
So we are talking about these steroid injections. So what happened that when we give the steroid injections for the plantar fasciitis, so these steroid injections, it creates more fibrosis within the tendon. So it makes more fragile. So steroid injection actually harmful into the case of plantar fasciitis or the heel pain. Second thing, it creates a fat atrophy for the heel pad. There is one fat pad beneath the calcaneum,
Saline.
and when we give the steroid injections for the treatment of heel pain, it creates atrophy into the